Hey future nurses, welcome back to Scrub and Spoon. If you are new here, I am Nurse Funke and welcome. Okay, and today's Nclex review is on 7 class of respiratory medications. So this is a very robust review because we are talking about antitussive. We're talking about class of respiratory medication: antitussive, expectorants, decongestants, mucolytics, antihistamine, also corticosteroids, bronchodilators. Okay, so this review is packed, so I'll encourage you to watch till the end, share to other nursing students that may benefit from this review. Okay, and don't forget to check out my website for the master method study guide. Okay, it contains 11 body systems and over 120 Nclex most tested disorders. These are like cheat sheets right in front of you, so check out my website. Link is in my bio. Now, without wasting too much of our time, let's go right into it. The first question says, a 58-year-old client with moderate persistent asthma uses a low-dose inhaled corticosteroid, which is fluticasone, now daily, and an albuterol inhaler, PRN, as needed. The client reports a new onset of hoarseness and white patches now on the tongue. Which instruction should the nurse give first? A, discontinue fluticasone and start oral prednisone. B, rinse mouth and spit after using the inhaler. C, use the albuterol more frequently to prevent hoarseness. And D, stop using both inhalers and call the provider. Pick your answer. Guys, the right answer is B, rinse mouth and spit after using the inhaler. Now, we will break this down. I also want you guys to know that I made a detailed video talking about these 7 classes of respiratory medications and the types of medication, the side effect, the treatment. It will be beneficial for you to go review that, know your content before doing this review. Okay, so let's see what's happening here. The 58 years old have moderate persistent asthma and they use these medications: fluticasone, which is inhaled corticosteroid, and albuterol, bronchodilator. Corticosteroid, we know what they do. They help to reduce inflammation in the airway, and albuterol is bronchodilator. What do? Bronchodilators help to open the airway. Okay, and if you've seen that video, I was talking about that. If your patient have to use both bronchodilator and corticosteroids, they use bronchodilator first to open the airway, and then we wait 5 minutes and use corticosteroids to reduce the inflammation in the airway, because after using bronchodilator, the airway is open and it's now easy for the corticosteroid that reduce inflammation in the airway to be absorbed and do its work in the airway. So now we've broken down the medication this patient is taking for asthma, right? But the client now complained, report new onset of hoarseness and white patches on the tongue. The reason why rinse the mouth is the right answer is because fluticasone, the inhaled fluticasone they are taking, can leave residual, the residual of the fluticasone can be left on the tongue, and that will cause, and over time, that will cause yeast infection to grow on the tongue, and that will cause oral thrush or oral candidiasis. Oral thrush is fungal infection of the mouth caused by the overgrowth of the candida yeast. Okay, and that will cause oral thrush. That's the white patches you will see on their tongue. And also because we know that corticosteroid, even though this is inhaled corticosteroid, fluticasone, it will, what do we know about the system? You know, there's inhaled corticosteroid and systemic corticosteroid. Go review that video so you can understand. Corticosteroids generally suppresses immunity, causes immunosuppression after a long period of time. Now, this fluticasone they are taking, even though it's inhaled, it can suppress local immunity in the throat and in the mouth, and this will allow the yeast infection to grow, and that is the white patches you will see. So the best practice is after each use of the inhaler of inhaled fluticasone, encourage them to rinse their mouth. Rinsing the mouth will help to remove the residual fluticasone on the tongue. Okay, and that will help to prevent the thrush. The oral thrush, oral candidiasis. Okay, now let's go through the wrong choices. B is the right answer. A says discontinue fluticasone and start oral prednisone. First off, you cannot discontinue fluticasone and start oral prednisone without a doctor's order. Do we get it? And to think that the prednisone you want them to switch to is a systemic corticosteroid, and systemic corticosteroids have more side effects: hyperglycemia, immunosuppression, infection risk. So we are not encouraging them to switch to oral prednisone. Like I said, it is systemic. Oral prednisone is systemic corticosteroid. Systemic corticosteroid can be taken either orally or via IV. Okay, so we are not encouraging them to do that. So rinsing the mouth and spitting out, rinsing the mouth is enough to avoid the oral thrush. It says use the albuterol more frequently to prevent hoarseness. Hold it right there. Don't let them trick you. How did we get to albuterol? Now look, yes, even though the question says it use albuterol as needed, but what is causing the oral thrush is not albuterol, is not bronchodilator. It is corticosteroid, the inhaled fluticasone. So even if you are using more albuterol, it's not going to prevent the oral thrush. Do we get it? So that is actually very, very wrong. And I need you to also know that overusing albuterol, which is bronchodilator, will have its own side effects, can cause tachycardia and tremors. So we don't want to ask them to use that. And guess what? Both the fluticasone and the bronchodilators comes with order. These are medications that will come with order. Use twice daily, 1 puff, 2 puffs. So you cannot just tell them to increase the dose. Okay, that's the work of the provider, the healthcare provider, the doctor. So that is totally wrong. And D says stop using both inhalers and call the provider. Abruptly stopping medications will cause exacerbation. Okay, it will cause exacerbation of the condition you're using it for. Now they are using the albuterol and the fluticasone for asthma attacks. If they stop it abruptly, that means that can lead to asthma exacerbation, and we do not want that. Okay, so we're not asking them to stop. Okay, the provider, even though the provider can be notified if the oral thrush worsen, but the first nursing action is oral care, not stopping the medication, because we know what we can do to stop this thing, which is rinsing mouth. Very easy. Oral care, rinsing the mouth, not completely stopping both medications. Okay, now let's move on. A client is prescribed guaifenesin, an expectorant, now for thick productive cough. Which statement should the nurse include in the teaching? Select all that apply. A says drink plenty of fluids while taking this medication. B, expect to feel drowsy, avoid driving. C, take this medication for a dry, non-productive cough. D, report if the cough lasts more than 1 week or is accompanied by fever. And E, this medication thins secretions, so coughing is more effective. Pick your answer, guys. Now, guys, pardon me, it is select all that apply, and we treat it as true or false. Now, let's go through it together. Let me explain what's going on here. Now, the client is prescribed guaifenesin, which is an expectorant. You need to know what is expectorant. Expectorants are used mostly for wet productive cough. And what is wet productive cough? That is when the patient cough, they cough out phlegms, mucus, something comes out, either phlegms, mucus. So that is wet productive cough. So expectorant is used for wet productive cough that is related or associated to some type of respiratory infections. Okay, so that is the use of expectorants. They help to thin the mucus so that it is easy to be expelled out or to cough out. Now that you know the function of expectorant, let's go through it. We are trying to select the statement the nurse should include in the teaching. Say, hey, drink plenty of fluids while taking this medication. Absolutely, because fluids help to thin the secretions, and that will make it easy for the phlegms, the mucus to come out, the respiratory secretions to come out. So this is correct. So B, expect to feel drowsy, avoid driving. Incorrect. Expectorant doesn't have sedative properties. They do not cause sedation, or they do not cause drowsiness too. So if you want to see if the patient is taking antitussive, like especially codeine antitussive helps to suppress cough. So if the antitussive contains codeine, yes, that will cause dizziness, drowsiness. But they are taking expectorant and it does not cause sedation or drowsiness. So telling them to expect to feel drowsy and avoid driving is not a proper teaching. It should not be included in that teaching. So that is wrong. C, take this medication for dry, non-productive cough. Absolutely wrong. If you have been following me, I told you it is that expectorants are used for wet productive cough because they help to thin those respiratory secretions, those mucus, those phlegms, and makes it easy to be coughed out. So this is wrong. It is not taken for non-productive cough. What is taken for non-productive cough is antitussive, because antitussive will suppress the cough reflex and decrease the frequency of cough, the cough that disturbs rest or sleep at night. So that will suppress the cough. But when a cough, or when patient coughs and it comes and there is phlegms, secretions, mucus, when they cough, they spit out all of that, you want them to cough more, because if you use antitussive, that will suppress the coughing, and that will cause retention of those mucus in the airway. Airway blockage will happen. Impaired airway, impaired gas exchange. That's not what we want. So we do not use expectorants for dry, non-productive cough. We use it for wet cough, productive cough so that they can cough it out. Because antitussive, we do not use antitussive for wet. We do not use antitussive for wet productive cough because antitussive will suppress the coughing. But with wet productive cough, patients need to cough out. They need to cough out those phlegms, those secretions, those mucus. Okay, so I try to explain antitussive and expectorant here, so I hope you get it. Okay, now this says report if the cough lasts more than 1 week or is accompanied by fever. This is correct because persistent cough or fever may signal secondary infection like pneumonia or another underlying condition that needs medical attention. So they should report if this cough lasts more than 1 week. Okay, and especially accompanied with fever. What do you know about fever? Infection, inflammation. Okay, so that should be reported. So that should be part of the teaching. And E, this medication thin secretion, so coughing is more effective. Absolutely, I explained that because expectorants will help to thin the secretion so the phlegms, the mucus can be expelled out, can be coughed out. So that is true. So our right answers are A, D, E. These are true statements that should be included in the teaching by the nurse. Now, let's move forward. Next question. A client with COPD is prescribed Acetaminophen inhaler. Which adverse effect should the nurse emphasize in teaching? A, oral thrush. B, dry mouth. C, bradycardia. And D, hypoglycemia. Pick your answer. Now, the right answer is B, dry mouth. Let's go through it together. The patient is with COPD and is prescribed Acetaminophen. Acetaminophen inhaler is anticholinergic bronchodilators. Okay, and what do you know about anticholinergics? They dry the body. You will see you see the mnemonic can see, which means they will cause blood vision, can spit, which means they will cause dry mouth, can pee, which means it will cause urinary retention, and can poop, constipation. So that's why our right answer, one of the side effects of anticholinergic bronchodilator like Acetaminophen this patient is prescribed, which this patient is using, is dry mouth. Okay. And the Acetaminophen, which is the anticholinergic bronchodilators, they're used for COPD, chronic bronchitis, emphysema, nasal congestion, rhinitis, runny nose, okay? And they can also be used for asthma off-label, okay? So that is why our right answer is B, dry mouth. Now, let's go through the wrong choices. A says oral thrush. What do we know about oral thrush that I've just told you guys? Inhaled corticosteroids, oral thrush, oral candidiasis, fungal infection on the tongue, corticosteroids, suppressed local immunity in the mouth, in the throat, yeast infection grow, oral thrush. So that's corticosteroid. So that is wrong. Acetaminophen will not cause oral thrush. C, bradycardia. Now, anticholinergics blocks the parasympathetic system, which can actually cause mild tachycardia and not bradycardia. Tachycardia, increased heart rate. Bradycardia, lower heart rate. And D, hypoglycemia, not related. Acetaminophen doesn't directly affect the glucose level. What can affect sugar or glucose level in the blood is either insulin or oral anti-diabetic agent, not Acetaminophen, okay? So that is wrong. Our right answer is B, dry mouth. Okay, so the nurse should emphasize this adverse effect in the teaching, dry mouth, because of the anticholinergic effect. Now, let's go through next question. Next question. A patient is started on pseudoephedrine for nasal congestion. Which condition in the patient history should the nurse flag as potential contraindications or cautionary? Select all that apply again. Hypertension. A, hypertension. B, benign prostatic hyperplasia. C, diabetes mellitus well controlled with metformin. And D, coronary artery disease. Now let's go through it together because it's all that apply. We treat it as true or false. But what's happening here? The pseudoephedrine, the patient is taking a systemic decongestant, and their mechanism of action is that they cause vasoconstriction in the nasal vessel, and this will lead to reduction in the swelling and congestion in the nose, right? But you need to know that the vasoconstriction happens everywhere in the body, not only in the nasal or in the nose. The vasoconstriction happens everywhere in the body. We are looking for conditions that will contradict the use of pseudoephedrine in a patient. Okay, now let's talk about this. A, hypertension. This is true. Hypertension will be contraindication, will be a condition that will contradict using pseudoephedrine in that patient. Why? Because one of the side effects of this decongestant is hypertension. So The blood vessel in hypertension, the blood vessels are already under pressure. So if you should give them pseudoephedrine, a systemic decongestant that also causes constriction of the blood vessel, this can raise blood pressure. This can lead to hypertensive crisis or poor blood pressure control. Now, if the hypertensive crisis is not controlled, hypertensive crisis, you will get blood pressure of like 180/120. Okay, if it is not controlled, that can lead to stroke, aneurysm, myocardial infarction, all those bad stuff, headache. We don't want that, and that is why we will avoid pseudoephedrine in patients with hypertension. So that is right. B, benign prostatic hyperplasia. This is actually correct. BPH will be a contraindication for pseudoephedrine. Why? Because let's break what is happening now. Let me explain what is BPH for you guys. Benign means, no, the BPH, B means benign, means non-cancerous. P, prostatic, means prostate gland, and the H, hyperplasia, means increased number of cells. Now let's break it down. Now the pseudoephedrine is sympathomimetic drug which cause smooth muscle contraction in the neck, bladder, and prostate, and this will worsen urinary retention in men, because the BPH the patient already have causes urinary retention. Let me explain it to you. The prostate is sitting just below the bladder and it surrounds the urethra. Urethra is the pipe, let's call it the straw or pipe that passes the urine out in men. Now this prostate that is surrounding the urethra is enlarged. That's hyperplasia. It's enlarged, and when it's enlarged, it's squeezing the urethra up. Now it's very difficult for urine to come from the bladder and go through this tiny straw or this tiny squeezed up hole. So in BPH, the patient already they will experience urinary retention, hydrophrosis, that is when there is backflow of urine into the bladder, weak urine stream, incomplete emptying, and so many other. So they already have a condition that is causing urinary retention for them. So if you should give pseudoephedrine that also relaxes, that also contracts the smooth muscle in the bladder, in the urethra, there will be urine retention. So we don't want that, because they already have a condition that is causing urine retention for them, which is the BPH. So that is why we will avoid this medication in patients, in men that already have benign prostatic hyperplasia. C, diabetes mellitus, well controlled with metformin. This is incorrect, because the medication pseudoephedrine can slightly affect the blood glucose or slightly increase the blood glucose. But the question says well controlled with metformin. This means it is a well controlled diabetes. So this effect is usually minimal. So increased blood sugar is usually very minimal with pseudoephedrine, even though you still use pseudoephedrine with caution in patients with diabetes, but it is not a strong contraindication, so you can still use pseudoephedrine in patients with diabetes. Okay, so that is wrong. And D, coronary artery disease. If you've seen that video, I mentioned it. Yes, this is a great contraindication in patients with coronary artery disease, because pseudoephedrine can cause vasoconstriction, and this will increase the heart workload and oxygen need, and this can trigger angina or dysrhythmias in patients with CAD, coronary artery disease. So that is why we will not use it for them. Okay, so our right answers are A, B, D. The only one that is okay to use with no much concern is C, diabetes mellitus. Now, a client with suspected opioid overdose is receiving naloxone in the emergency department. Which respiratory pattern finding suggests the naloxone has had a therapeutic effect? A, respiratory rate increases from 6 to 18 breaths per minute and spontaneous cough returns. B, respiratory rate remains 6 breaths per minute but deeper breaths are observed. C, clients develop frequent loud snoring respirations. And D, clients remain apneic. Guys, pick your answer. Guys, the right answer is A, respiratory rate increased from 6 to 18 breaths per minute and spontaneous cough returns. Let's go through the situation. Now, the client is using naloxone under the brand name Narcan for opioid overdose. And we know that opioid overdose will cause respiratory depression, suppresses the central nervous system. So naloxone is given to reverse the side effect of the opioid overdose. A good therapeutic effect of the naloxone that is used to reverse the opioid overdose will be the respiratory rate jumping from 6 to 18 breaths per minute. Normal respiratory rate is 12 to 20 breaths per minute. Okay, and also spontaneous cough returns. So that's why our right answer is A. Okay, and opioids are medication. Let me explain that. so that you can also understand better. Opioids are stronger pain medications like hydromorphine, oxycodone, okay? And the other example of opioids that may be illegal, heroin, that's illegal. And this medication, they will suppress the respiratory rate, like I have explained. And that's why you see bradykinin, which is low respiratory rate that you see. That's naloxone reverted from 6 to 18, okay? You can also see apnea, that is involuntary cessation of breath because of the respiratory suppression. Opioids will suppress the respiration, can suppress the central nervous system, okay? So a therapeutic use of naloxone is we seeing that the respiratory rate has now jumped from 6, where it was depressed before, to 18, which is within the normal range, because normal respiratory rate is 12 to 20, okay? So A is our right answer. Now let's go through B. Respiratory rate remains 6 breaths per minute, but deeper breaths are observed. That is ineffective reversal. The naloxone is not working yet. Has not reversed the opioids overdose signs and symptoms, which is respiratory depression. So if the respiratory rate still remains 6, then the naloxone is not effective. Even though it says, but deeper breaths are observed, that alone is not enough. The respiratory rate is still critically low. So the patient remains at risk of hypoventilation and CO2 retention if the respiratory rate is still at 6. Okay, so that is wrong. And C, clients develop frequent and loud snoring respiration. This is signifying obstructed airway, not improvement. The naloxone is not effective here if the client still develops frequent and loud snoring respiration. Okay, so snoring respirations indicates partial airway obstruction. Okay, the tongue is relaxed, but the airway is still blocked. This will signify that this patient is still not fully awake. Airway is still compromised. So that is wrong. So when you see this, you know that the naloxone is not effective yet, hasn't given the therapeutic effect we're expecting. And D, clients remain apneic. That is, there's no therapeutic effect in this one if the clients remain apneic. That is sort of apnea, involuntary cessation of breath. So the naloxone has not given us the therapeutic effect we want. So this will not be considered therapeutic. This is wrong. And in this situation, the nurse can repeat the naloxone per protocol of the facility, because each facility have their own protocol. Okay, the nurse can also support ventilation with bag valve mask. Okay, so our right answer here is A, respiratory rate. When you see this, you know that okay, the naloxone has reversed the opioids overdose symptoms. Okay, let's move on. A patient with cystic fibrosis is receiving Donase alpha pulmozyme now via nebulizer. The nurse should monitor for which expected therapeutic outcome. A, increased blood glucose level. B, decreased viscosity of pulmonary secretions. D, bradycardia with nebulizer use. And C, systemic corticosteroid suppression. Pick your answer, guys. The right answer is B, decreased viscosity of pulmonary secretions. Now let's go through it together. What are they using? The patient is using Donase alpha. Donase alpha is mucolytics. They help to thin the secretion. They break down the mucus chemically and help to thin the secretion for easy coughing out. It makes it easy to cough it out, the thin and break down the mucus. Okay, so and we are looking for expected therapeutic outcomes. So if your patient is on Donase alpha, when you see that there is decreased viscosity of pulmonary secretion, viscosity of pulmonary secretion is the thickness. So Donase alpha helps to decrease the viscosity, the thickness of the mucus or the thickness of the respiratory secretion, and this makes it easy to come out, to be cut out. So when you see that, that is true. That is therapeutic effect of Donase alpha. Now let's go through the wrong choices. A says increase blood glucose level. Absolutely not. Donase alpha doesn't affect the blood glucose level, so this is wrong. B, bradycardia with nebulizer use. Bradycardia, which is low heart rate, but the Donase alpha they are using doesn't have any effect on the heart. It does not affect the heart. So bradycardia with nebulizer use is not a typical effect of Donase alpha. So that also makes it wrong. Now, D, systemic corticosteroid suppression. The medication they are taking is mucolytics. And this option says systemic corticosteroid suppression. If they are taking corticosteroid, yes, because corticosteroids, systemic corticosteroids, can suppress the immune system. And that's why you see the patient with long-term use of corticosteroid will have increased risk of infection because they have immunosuppression. But what they are taking is Donase alpha, which is a mucolytics, not corticosteroids. So that makes it wrong. Okay. Now let's move on. A patient with allergic rhinitis is prescribed diphenhydramine, first generation antihistamine, which is diphenhydramine is also Benadryl. I hope you know that. So the generic name is diphenhydramine and the brand name is Benadryl. You see it over the counter. Okay. Which instructions should the nurse include? Select all that apply. A, this medication may make you sleepy. Avoid driving. B, chew sugar-free gum for dry mouth. C, you can drink alcohol with this medication to help you sleep. And D, if you have trouble urinating, call your provider. Since it's select all that apply, let's go through it together. Now, like I've told you, the diphenhydramine is Benadryl, and it is the first generation antihistamine. There is second generation antihistamine. Now let's talk about the key difference between first generation and second generation antihistamine. First generation antihistamine, they have sedative property. They cause sedation. They have anticholinergic effects like can't see, can't spit, can't pee, and can't poop. While second generation antihistamine, an example, that's example Benadryl. Example of second generation antihistamine includes loratadine, cetirizine, right? For second generation antihistamine, they do not cause sedation and they do not have anticholinergic effect. So that's the difference. Now that you know about the medication, let's go through it together. So instruction the nurse will include for patient taking diphenhydramine will be A, this medication may make you sleepy. Avoid driving. I just said that they cause sedation. So when a medication causes sedation, it's best encouraged to take it at night because you want to avoid operating heavy machinery or driving until you know how this medication affects you, because you don't want to cause any accident. Okay. Now, so that's true. Now, B, chew sugar-free gum for dry mouth. I just told you that first generation antipsychotic. I just told you that first generation antihistamine, they have anticholinergic effects. Can't spit, that is dry mouth. Can't see, that is blood vision. Can't pee, that is urinary retention. And can't poo, that's constipation. So you chew sugar-free gum for dry mouth. This is also a true teaching, right? Now, see, you can drink alcohol with this medication to help you sleep. Excuse you? In what history have you seen this kind of teaching given? Alcohol is always to be avoided, never to be missed. Even if you do not know about this medication, but you know alcohol should not be taken with any medication. Alcohol suppresses the central nervous system. Now, this medication, diphenhydramine, also causes sedation. If you should combine it with alcohol, severe sedation, respiratory depression, we don't want that. So never, this can never be a teaching, never ever to drink alcohol to make you combine alcohol with this medication to help you sleep. Never you give this kind of instruction. Okay, so that is wrong. And D, if you have trouble urinating, call your provider. Absolutely. One of the anticholinergic effects diphenhydramine have is urinary retention. Can't pee. So if the patient have trouble peeing, they have to report to the healthcare provider, because we don't want them to keep storing the urine in the bladder, because UTI can happen, urinary tract infection. Bacteria can grow in that bladder if the urine is not coming out. So they need to report this to the healthcare provider. So our right answers are A, B, D. Those are correct instruction the nurse should include when teaching a patient starting diphenhydramine. And also, especially in men, remember, if a man has BPH and they take diphenhydramine that causes urinary retention, that will worsen it. So they need to report that to the healthcare provider. Let's move on. Now, a client with suspected acetaminophen overdose is administered acetylcysteine. Now, aside from its hepatoprotective role, which respiratory adverse effect should the nurse watch for when acetylcysteine is given via nebulizer? A, bronchospasm. B, laryngeal edema. C, pulmonary fibrosis. And D, apnea. Now, let's go through it together. The right answer is A, bronchospasm. I will explain it. This client is suspected of acetaminophen overdose. And our antidote for acetaminophen is acetylcysteine. Now, hold up. Acetylcysteine have two major roles in nursing practice. It is used as acetaminophen antidote, as is stated here. And it can be used as mucolytics in patients with cystic fibrosis, with those sticky secretions or mucus. It can also be used in COPD patients when it is used as mucolytics. It can also help to prevent atelectasis, which is collapse of the lungs. Because in cystic fibrosis, the sticky mucus will build up in the lungs and cause infection, and over time, this can damage the lung. So acetylcysteine is used as mucolytics in cystic fibrosis. So that's good, and it's also used as acetaminophen antidotes. Now, when acetylcysteine is used as inhaled mucolytics, right, it directly irritates the airway, and this can trigger bronchospasm. And that is why our right answer is A, bronchospasm. Okay, this is a respiratory adverse effect the nurse should watch out for. Now let's go through the wrong choices. Now B says laryngeal edema. This is not typical reaction of acetylcysteine, so that is wrong. Pulmonary fibrosis. This is a chronic lung condition, not an acute drug reaction. So pulmonary fibrosis is not an acute drug reaction of taking acetylcysteine. Okay, so that is also wrong. And D, apnea. Now acetylcysteine does not depress the central nervous system or respiration, so acetylcysteine will not cause apnea. So the major adverse effects the nurse should watch out for will be bronchospasm, because the medication irritates the airway and can trigger bronchospasm. Okay, let's move on. A patient is prescribed a daily inhaled corticosteroid for asthma control. Which statements indicate the patient understands teaching? Selected out by A, I will use this inhaler only when I feel short of breath. B, I will use my rescue inhaler first if I have sudden shortness of breath. C, I will raise my mouth after using the inhaler. And D, I will expect immediate relief of wheezing with this inhaler. Pick your answer. Now, since it's selected that apply, we'll go through it together, but let's see what's happening here. The patient is prescribed a daily inhaled corticosteroid, okay? Reduce inflammation in the airway, right? That's the function of corticosteroid for asthma control. Which statement indicates patient understanding of teaching? If the patient say A, I will use this inhaler only when I feel shortness of breath. This is wrong, because why? This question says it is prescribed for a daily the question says a patient is prescribed a daily inhaled corticosteroid. This means it should be taken daily and more likely a maintenance dose, not only to be taken when you feel shortness of breath. Most likely, this is maintenance dose, and it is to prevent onset of asthma attack, not a rescue inhaler, which is albuterol. So if the patient say I will use this inhaler only when I feel shortness of breath, that is true, because the question says a daily inhaled corticosteroid is prescribed for them, so they have to take it daily regardless of feeling shortness of breath or not. And when a daily inhaled corticosteroid is prescribed, it is then prescribed as a maintenance dose to prevent onset of asthma attack. So it is meant to be used daily and not as needed. Now B, I will use my rescue inhaler first if I have sudden shortness of breath. Absolutely. When you use your rescue inhaler first, that is albuterol to help open the airway. Okay, so this statement is true. They will use their rescue inhaler first, like albuterol, to open the airway. Albuterol is a short-acting beta agonist. SABA should be used first during acute asthma attack before the long-acting beta 2 agonist. Okay, so in acute asthma attack, rescue inhaler first, then they can use maintenance inhaler next for better absorption. So B is true. So C, I will rinse my mouth after using this inhaler. This is true. Why? Because the medication they are taking is corticosteroid, inhaled corticosteroid, like fluticasone. Remember I told you. And if they do not rinse the mouth, the residual fluticasone or the residual medication can stay on the mouth and cause oral thrush. And we do not want that. So they should rinse their mouth after taking that inhaler. And D, I will expect immediate relief of wheezing with this inhaler. This is incorrect, because the prescribed daily inhaled corticosteroids is for maintenance dose. It will not give you immediate relief of wheezing. It is to majorly prevent asthma attack. That's why its maintenance dose is taken daily. Okay, so this is wrong. Okay, for acute wheezing and you want to see you want to see immediate relief in wheezing, they have to use the rescue inhaler, which is the albuterol, not the prescribed daily corticosteroid inhaler. Okay, so that is wrong. Now, a client with theophylline therapy has a serum level drawn and the result is 28 mcg by ml, and the therapeutic range for theophylline is 10 to 20 mcg by ml, right? Which signs and symptoms is most consistent with theophylline toxicity and should be prioritized? A, mild tremor and nausea. B, seizure and ventricular dysrhythmias. C, transient headache. And D, slight hyponatremia. Let's go through it. They are taking theophylline, which is xanthine derivatives. They are used for long-term control of asthma and COPD. And their therapeutic range is between 10 to 20. Now, the serum level, blood is drawn regularly to monitor the serum level of theophylline, okay, in the patient's, right? In the patient's blood, right? Now, the question is saying that the theophylline level is now 28 mcg and the therapeutic range is 10 to 20. So there will be theophylline toxicity signs and symptoms because the level is way above the therapeutic range. So our right answer will now be seizure and ventricular dysrhythmias. This is some of the theophylline toxicity you will see: seizure, arrhythmias, ventricular dysrhythmias. You can also see headache and GI upset. So those are signs signifying theophylline toxicity. So that should be prioritized. These seizure and ventricular dysrhythmia as signs and symptoms of theophylline toxicity should be prioritized. Now let's go through the wrong choices. A, mild tremor and nausea. You hear it, mild tremor and nausea. They should be monitored, but not immediate priority. And it's not immediately life-threatening, so that is wrong. Now, transient headache. Now, this is not life-threatening, and transient headache can happen even at the therapeutic level of theophylline, or even at the toxicity level of theophylline. So this is not life-threatening. D, slight hyponatremia. This is not a hallmark of theophylline toxicity. It even says slight hyponatremia, okay? Electrolyte changes like hyponatremia are typical in theophylline therapy. So mild hyponatremia is not urgent in this context, okay? So that makes our right answer that will take priority would be the seizure and the ventricular dysrhythmias. Because look at them, seizure and ventricular dysrhythmia. Seizure is central nervous system symptoms, while ventricular dysrhythmia is a cardiac symptoms. So this should take priority over the rest. Okay, now let's move on. Now, a client with acute bronchitis asked about using dextromethorphan to control coughing at night. Which statements are correct teaching points? Selected that apply. A, dextromethorphan can help when coughing prevents you from sleeping. B, dextromethorphan should be used when you need to clear tick secretions. C, avoid taking dextromethorphan with other central nervous system depressants. And D, do not use dextromethorphan for productive coughs where mucus needs clearing. So since it's selected that apply, we'll go through it together, okay? Now let's go. The dextromethorphan the patient is taking is antitussive. And what do? They suppress cough reflex and prevent the frequency of coughs that disturbs you from sleeping at night or from rest, right? So if the patient says dextromethorphan can help when coughing prevent you from sleeping, this is actually correct from the explanation about this medication. You know that is correct. B, dextromethorphan should be used when you need to clear tick secretions. I have explained earlier that antitussives are not used for wet productive coughs. When it says when you need to clear tick secretions, this means this is wet productive coughs, and expectorants is what is used, not antitussives, because antitussive will suppress that cough, and when the patient is not coughing out the mucus, the secretions, it will clog up and impair the airway. It will affect gas exchange in the lungs if the secretions are in the lungs. Okay, so this is wrong. Okay, and C, avoid taking dextromethorphan with other central nervous system depressants. Absolutely, because it can cause slight sedation. So avoid taking it to other central nervous system depressants to avoid severe sedation or severe depression of the central nervous system. Okay, so this is true. Central nervous system depressants like alcohol, opioids, or other sedatives can increase sedation risk and respiratory depressions, like I've mentioned earlier. Now, D, do not use dextromethorphan for productive coughs where mucus needs clearing. This is true. I've explained it. When you need to clear when patient needs to clear out the secretions, do not use antitussive. So that is actually true. Okay, because let me explain again and again. If the sticky mucus, or if the mucus or the secretions, the phlegms didn't come out, it can cause infection. It can cause pneumonia, airway obstruction, impaired gas exchange. That is why. I hope you get it. Okay, so our right answers are A, C, D. Okay, these are correct statements, teaching points. A, C, and D. Okay, so let's move on. Next question. A patient with emphysema uses Tiotropium, okay, long-acting anticholinergic, daily, and reports constipation and blood vision. Which nursing actions / teachings are important? Selected that apply. A, encourage sugar-free candy and adequate hydration for dry mouth. B, instruct patient to report difficulty urinating. C, tell patient to stop Tiotropium immediately if constipation occurs. D, explain blood vision may be an anticholinergic side effect and report if severe. Okay, now let's break it. The medication Tiotropium is a long-acting anticholinergic bronchodilator, and they're using it for emphysema. Now, with the medication being anticholinergics, you know they will have this anticholinergic effect that I've been mentioning. It can see, can spit, can pee, and can poo. Now, let's go through the question together. Encourage sugar-free candy and adequate hydration for dry mouth. Yes, because the medication is anticholinergics. They dry up the body. So, encouraging them to take sugar-free candy will help with the dry mouth they will experience when being on this medication. Now, B, instruct patients to report difficulty urinating. True, because of the anticholinergic effects. Can't pee, which is urinary retention. Okay, so they need to report this, especially with men with BPH, benign prostatic hyperplasia. Okay, because I've explained why before. And C, tell patient to stop Tiotropium immediately if constipation occurs. Constipation is common effect of anticholinergics, so it's expected. You can encourage them to increase fluids, increase fiber in their food, not stopping the medication abruptly. Okay, so that is wrong. Now, D, explain blood vision may be an anticholinergic side effect and report if severe. Absolutely, because can see blood vision. It is common side effect of anticholinergics, but it should be reported if severe, so that it doesn't lead to blindness, or it should be reported if it interferes with daily activities, because this may indicate high pressure issue, so it should be reported. Okay, guys, that is actually our last question. I'm so excited we got through this review. Thank you for staying till the end. Take care. Don't forget to subscribe, like, share, and take care.